Good morning and happy Teach Me Tuesday. We're coming from a new location today. It is my day off and there's some construction in my house, handyman work going on. So I came to my local coffee shop, which also is in the grocery store. So just to record this. Today we are talking about my top probably three favorite things to teach, which is NRP. I have been an NRP instructor for about 8 or 9 years now, and I love it. And I love the evidence-based practice of it. And of course, I love how NRP introduced simulation into the NICU environment many, many years ago. This is going to probably be a three-part series. I already have 3 parts planned. I think I'm going to wrap it up in 3, but stay tuned. So today we are going to start with the beginnings and the basics of NRP and strategies for successful resuscitations. So let's review. When we think about NRP, if you've taken it recently, you see, oh, it's the 8th edition, so they just must be updating things. But NRP really came out of a foundation in the early 1970s when the American Academy of Pediatrics, or the AAP, realized everybody was kind of resuscitating babies differently. It was very regional. It would be like, okay, well, I had success doing this in this location, so we clearly should just try that again. So they came together with the American Heart Association and created the NRP program. We are now in the 8th edition, and the reason that is because this is an evidence-based program. And so as new evidence comes forward, NRP updates their books. I saw some new potential updates when I was at NAN this year, so that was pretty exciting. But that is probably what I love most about NRP book is just how current it stays and how they really, it's like they put one out and then they immediately go back in for steering committees and are like, okay, what can we do differently? Have we made the best recommendations? Is there new evidence out there to support a change in practice? And they have changed things over the years. If you have been a NICU nurse for any amount of time, probably greater than 5 years, I'm coming up on 20, you know we've made many changes, such as our meconium, focusing on temperature, getting PPV started immediately, not starting on 100%, right? Mind blown. So let's talk about what resuscitation is like now in the 8th edition of NRP in the NICU setting, and kind of how can that help us within our at our delivery setting, and how can that help us within our NICUs. So when we think about the initial steps of NRP, we always remember warm, dry stim, warm, dry stim, warm, dry stim, right? And that is the most important. But now with delayed cord clamping, we are still doing that, and hopefully doing delayed cord clamping for a bare minimum of 30 seconds, but hopefully up to 60 seconds. And hopefully that delayed cord clamping is happening while the baby is also getting warm, dried, and stim. So the OB provider, whether they are putting the baby up on mom and doing warm, dry stim here, they're doing it at the C-section incision. Maybe we're putting the baby into a plastic wrap at the time of delivery, whatever it may be, the provider there is watching for signs of vigor. So how do we define, is the baby vigorous, right? Maybe someone's asked you that. Is the baby vigorous? That is the baby crying or breathing? What is the heart rate? And does the baby have tone? So important things to remember is if the baby is crying, they are breathing, and their heart rate is probably greater than 100. So that's like your greatest first sign. And hopefully they have tone in those times. If any of those things change over the course of time, the baby, of course, might need to be brought to the warmer. But during all of this time, we really are focusing on thermal regulation. So keeping that baby warm, receiving the baby in those warm blankets, maybe getting the baby skin to skin and doing that skin to skin and right on the mom's chest for this warm, dry stim during delayed cord clamping. If you have seen any of my recent posts about the Incubator podcast, they did a 5-part series about 5 parts, maybe 6, about thermal regulation. And one of them specifically was talking about delivery room strategies. So highly recommend going and checking out that podcast episode if you're interested to see what people are kind of looking at. So we've done our initial steps. We're doing warm, dry stim. We're really focusing on, hey, how can we keep this baby warm? And if at any point the baby does not appear vigorous, they need to be brought to the warming table, because if they have any of those signs where they are not crying, they are not breathing, they have lost their tone, we need to be taking the next steps of resuscitation. So we need to be evaluating that within 30 seconds, and then remembering if the baby is not breathing or they are gasping, that PPV needs to be initiated. There are going to be things in our future. I know it. I feel positive about it. I know people are trialing it where they have little tables that they can put next to mom and do PPV right there. Not all units are equipped with that. So at that time, we would need to stop the delayed cord clamping and move the baby over to the table. While on the table, we can continue to warm, dry stim, but we have already probably passed that initial 30 to 60 seconds. So we need to be doing an effective assessment of how is the baby ventilating. Because what we know from NRP, that the single most important step of resuscitation is ventilation. We need to be able to ventilate these babies because the majority of the problems, whether you're in an NICU and the baby is a couple weeks old or you're at a delivery, is our babies have respiratory problems. So we don't have babies with like big cardiac problems where an adult, you're like, okay, we gotta like get the heart pumping and circulate that blood, change our cardiac output. We need to get our babies ventilated. So automatically, and anytime you have apnea, gasping, or a heart rate less than 100, you must begin PPV, positive pressure ventilation. So that is when you are doing your breathe 2, 3, breathe 2, 3, clearly using a TP resuscitator here, or breathe 2, 3, breathe 2, 3. And keeping in mind that, you know, if the baby's breathing with a heart rate over 100, they're ventilating. So then we can back off on what we're doing for our ventilation. But the vast majority of our babies, when you read the NRP book and it says 90% of babies are born totally fine, 10% require resuscitation, where only 1% require extensive resuscitation, that 9% in there is this ventilation. It is PPV. It is those initial breaths. And if we can do that well, most babies are going to do just fine in their transition. So how do we fix what's wrong? So our number one sign that our PPV is effective is rising heart rate. When I ask that question in NRP classes or during mock codes, we often get the answer that chest rise is the number one sign that our PPV is effective. While chest rise is important and it is telling you the size of your breast and if there might be an obstruction, if your heart rate is not rising, your ventilation is not effective. So that is when our old friend, Mr. SOPA, comes in. What the 8th edition of NRP tells us is that we should kind of do those things in twos. So we do the Mr., so mask readjustment, reposition the head, pause and ventilate. Give the baby a good 5 breaths. That's about 15 seconds, right? Because we're doing breathe 2, 3, breathe 2, 3, where the breathe is inspiratory time and the 2 and the 3 is expiratory time. Okay, heart rate's still not coming up. Okay, we're going to do the S and O. We're going to suction. We're going to open the mouth. Breathe 2, 3, breathe 2, 3, 5 times. Now we might need to increase our pressure. At this juncture, we need to have other personnel with us. If we are just bedside nurses in the NICU doing this, we definitely need to get more help. If we're at a delivery, we need to make sure we have a licensed personnel with us because our next step is going to be that alternative airway. But typically, if we can fix it with the Mr. or the SO, again, we are going to get effective ventilation that is going to allow our baby to have a safe recovery of this resuscitation. While this is going on, you could be asking yourself, what can I be doing? So we brought the baby to the table. So we need to get that oximeter on. Remembering our oximeter goes on our right wrist because our right wrist is going to be our pre-ductal saturations. We can get our OG into vent. Remembering during bag mask ventilation, some of that air is going to go into your stomach. If your stomach is expanding, that is pushing on your diaphragm and your ventilation is not going to be as effective. We might need to increase our oxygen. Of course, we're going to follow the parameters that NRP has set out for us, which means pretty much by 5 minutes, we need to be a SAT of 85. It feels like a crazy, unlofty goal, but it's true. So if we're at 75 at 3 minutes, we're probably doing okay. Again, I don't have that chart memorized. It comes up at most deliveries. We might need to place leads. NRP in the 8th edition recommends that we put leads on during any time we're going to place an alternative airway. So this might be our time for that. We could be asked to auscultate the heart rate and the breath sounds. And of course, we want to maintain warmth. So getting that temp probe on in a position that it's going to stay on, replace blankets, put the hat on. Obviously, if this is a micro premature baby, we have them in the poncho. We have them with plastic wrap. We have maybe a portal warmer or some sort of warming underneath them. But what the side rails of either a radiant warmer or a giraffe bed or a baby Leo, whatever, up so that we are not getting conductive heat loss either. So those are things that we can be focusing on as we are moving through those steps of PPV. We can also be anticipating, what would I assume is going to come next if this is what is going on with my baby? So if we're getting to the step of intubation, so we need to prepare for intubation. If we're in the NICU, maybe our head is at the top where the provider can't get to. We need to turn the baby. We need to position the baby. We need to get our suction ready. We need to remove things that could be barriers. Is your baby on a specialty mattress? Do they have a gel pillow? Are they swaddled? Let's prepare the baby the best that we can for this. At a delivery, we typically are receiving the baby in that position for intubation, but obviously getting them in a comfortable position, making sure they're still under the heat. We need to evaluate, do we have enough people here? Because if we're at this type of intubation, we probably need a bare minimum of 4 to 5 people. So do we have enough people here to make sure that we can get all of our tests done? And then, of course, if our heart rate remains low, how would I anticipate getting ready to do chest compressions? So those are the things that we're thinking about during the next steps. If our PPV is not showing that it's effective, remembering that the number one sign that our PPV is effective is a rising heart rate. So even if your heart rate is not less than 60, but it's not greater than 100, we're stuck in that in-between zone and we need to get to our alternative airway. We're going to need to be prepared for intubation. One thing that's really important during all of this is that as more people arrive, is that we have role identification. NRP talks so much about teamwork, which is going to be one of our 3 slide decks in this NRP series. But really, we need to identify that clear leader and then make sure we have other roles assigned, whether that's a documenter, other medical team members. Remember, the leader should not also be a doer. So if your medical team member that is present is going to be intubating, we probably need someone else to prepare us with other orders. We have someone getting medications ready. We need a respiratory therapist there. If you are at a small delivery hospital, you might not have a respiratory therapist at every delivery. So maybe they need to be coming from the emergency room or the adult ICU to come in and help. If this is in the NICU, if it's in a delivery room, we need someone with the role of parent support. Are they over explaining to them what's happening? And then, of course, we need to have multiple nurses present to be, helping with the airway, helping with anything else that may happen, compressions, medications, etc. So these are those first steps that happen in NRP. Remembering that if we can get effective ventilation, most of the times we are not going to need to progress to what is next. So the keys to successful initial steps of resuscitation are thermoregulation, ventilation, and role identification. If we can do that, we probably don't even need to look at our other slide decks, right? We wouldn't need to think about what would come next. But knowing effective ventilation is going to get us to our goal the vast majority of time. So whatever we need to do to correct the inappropriate steps, things that are not going well with our ventilation, is going to help us be most successful. Next Tuesday, we're going to talk about what goes wrong if we do get to the A of Mr. SOPA and things are still not going well during our resuscitation. And then we'll talk about what teamwork looks like the Tuesday after that. So we got our December plan. We're going to have a December to remember about NRP. So thanks for joining us today. Sorry, we had to kind of change locations. We'll get back to my gray and white curtains next week. Please let me know if you have any questions. Thank you for joining today. And I will see you next Tuesday for another round of Teach Me Tuesday.